Hello, welcome to this April 1st edition of Talks on Tuesday. As you're joining us, go ahead, if you will, and open up the chat. We're going to be using that throughout our webinar today. If you'll go ahead and in the chat, put in your name, where you're coming in from today, or you're joining us from today, and then also what role you have in the field of early intervention or in work with young children and their families. I'll take just a moment to let everyone get settled in and look to see where folks are coming from. I am calling or zooming in from Lexington, Virginia. I see Becca is not far from me in Rockingham and Harrisonburg. And then we have some North Carolina folks, it looks like, Richmond area, Charlottesville area, Tennessee. Oh, we've got Connecticut. Hi, Liz. Hi, Kate. All right. And then I'll tell you in just a moment where our presenter, Kimberly, is calling in from. I've got to stop saying calling. I feel like I'm so dating myself. Okay, well, it looks like folks are here and ready to roll. So let's get started then. So as I said, this is the April 1st edition of Talks on Tuesday. We're in our part 2 of a 2-part series on feeding challenges and supporting families through parent-led interventions. We have Kimberly Holt here with us today, who is an occupational therapist residing in North Carolina. All right, if you'll go to the next slide, Kimberly. All right, we're going to let Seth talk with us about Zoom accessibility tips.
Hey guys. We have a few Zoom accessibility tips that will better cater to your experience. Zoom allows auto-generated captions, and so if that's something you want, you can select that down in the bottom of your Zoom menu. Zoom also has keyboard shortcuts to help control your meeting if you prefer not to use a mouse. You can check that out in the Zoom settings, and then also screen readers work with Zoom, so you can customize your screen reader to have audible announcements with your settings. And if you have any tech questions during this webinar, you can private chat the guy that is the cow with the purple sweatshirt.
Thank you. All right, next slide. Yes, Corey, I can't even. So Seth is keeping us in the spirit of April Fool's Day. You all, that was just a little bit of fun there because you noted this only comes around, right? Every 6 or 7 years, depending on leap year. So we wanted to have a little fun there. Thanks, Seth, for that. These talks on Tuesdays are always in support of professional development towards the Division for Early Childhood's recommended practices. So here are just 3 of the recommended practices that this Talks on Tuesday supports. All right. What I'd like to do next is go ahead and introduce Kimberly then Holt. Those of you who attended our part 1 last month in March had an opportunity to learn with Kimberly Holt. And if you didn't see part 1, totally fine. It's archived, and we'll give you a link to that at the end. But we're really thrilled that you were able, Kimberly, to give us more, really bring this into 2 sessions and give us more in-depth information. So I'll go ahead and turn it over to Kimberly to give those of you who haven't met her just a little bit of background on what brings her to us, and then she'll dive right into the session.
Thank you very much. And I'm so happy to be here again with this group. Just a little bit about me. I've been an occupational therapist for about 19 years. I've worked in a variety of settings, and currently I work in early intervention in the home health setting in North Carolina. And throughout my time, I have learned that families are in desperate need for help with feeding and mealtime, so I have sought specialized training in that area. I'm currently getting my doctorate degree through the Medical University of South Carolina, and this is part of what I'm trying to give back to my community and my career. And so I just appreciate you all being here today. we are going to go over, just a little side note, we're going to go over the first part of our session 1 where we talked about 2 of our learning objectives. So I'm going to review that information. So if you weren't here at that meeting, then that's fine. I'm going to give you a little summary, so don't fret about that. Just a few housekeeping things. I have a pre-survey and a post-survey. It's via RedCap, which is a very easy to use program. We're going to provide you with a QR code I have on my screen, but we're also going to provide you with a link. So if you could please fill that out. This is shorter. It's about 4 questions. It shouldn't take long at all. And I will not be collecting any identifiable information. And it just helps me to improve my presentation for my doctorate degree. Please raise your hand or just notify Lorelei if you have a question. Put it in the chat. She's going to be looking for that. And I welcome being stopped during any point in this presentation for questions. I feel like answering them right away is the best way to go. So let us know. And then in our 50 minutes together, there will be interactive slides that will involve Zoom polls and chat. And I just encourage you to participate in that as you can. It gives me a lot of good information and all of us that are participating. So I appreciate that. So here is the QR code, and then we'll put the link in the chat for the pre-survey. I'm going to give you just a few minutes. I think it's like a 4-question survey, not long, not as long as the one that we did last month. So it's very simple. Just put what you know. There's some things you won't know, or maybe you do. So I will look forward to seeing that. So I'm going to give a few minutes. All right, we'll go ahead and get started. So just to review, in our last session, these were our 2 learning objectives that we addressed. Identify feeding delays and concerns among infants and toddlers, and promoting responsive feeding practice to build caregiver skills and confidence in feeding and mealtime participation. So feeding delays and concerns, we talked about 3 different things, and I'm going to reference many things throughout this presentation. And I have a resource handout that we will provide via the link. We can provide that now, if that would be okay, Lorelei, and at the end. But during our time last month, we talked about identifying the problem. We talked about 3 things, using and identifying using physical signs, which is what we're kind of all used to doing. And then we brought up 2 different ways, which is to use a developmental feeding chart. And then we talked about using parent-reported outcome measures. We talked about the different types of parent-reported outcome measures and where to find them. And I pointed to a website that I like to use where you can download these parent-reported outcome measures and really get your families involved in how to identify the feeding delays that they're seeing at their table with their infants and toddlers. Our second learning objective, we talked about responsive feeding and the importance of it. We talked about how it was a child signaling, a caregiver recognizing those signals correctly, and then how our babies are experiencing a predictable response. So we really define responsive feeding and then talked about how we can help our caregivers identify those child signals correctly. So again, if you want to know more about this and weren't at part 1, I encourage you to watch it. But then that leads into our 2 learning objectives for today. And this is our part 2. We are going to learn how to apply a coaching strategy to improve 3 things. We're going to specifically look at nutrition, positioning, and appropriate tool use during mealtime amongst our infants and toddlers. And then we're going to learn kind of the biggest reasons why we want to encourage an intervention strategy like this that empowers our parents to advocate for their children throughout their lifetime. So just first, we're going to start with a Zoom poll. How confident are you with using a coaching approach or model to support families with feeding challenges? And I'm really thinking I'm going to see differences from this education session to some of my others in the past because a lot of you do work in early intervention. So I'm excited to see. Okay. All right. Okay, so some really good responses. So we have 55% at confident, I'm surprised though, only 12% at very confident. And then 23% at not sure, and 10% at non-confident or at not confident. In the past, when I've done this presentation, I've had a lot more percentage in the non-confident, non-sure realm because of the other home healthcare workers that I was speaking to. So I'm really excited to be speaking with y'all who do know a lot about the coaching model and strategy. So thank you for that. 55% confident. Oops. All right, so let's move on. Okay. So, again, this is our graphic for what we're learning in this two-part series. It's a parent-led intervention strategy for feeding problems. We talked about how to identify the problem, and then we talked about how to observe the parent and facilitate responsive feeding. And now we're going to talk about how to apply a coaching model to improve. So the 5 coaching characteristics are joint planning, connecting with the caregiver. And this is really important, as you all know. What are you seeing? What are you feeling, caregiver? What are you needing? The second coaching characteristic that we're going to talk about is observation. So this is always in the natural environment, especially with our early intervention friends, and you're going to actually be watching mealtime. The third we're going to talk about is action or practice. This is a planned or spontaneous activity in the context of our real life activity. So for mealtime, this is actually sitting and planning for mealtime and snack time. But we can also work on mealtime during playtime as well. And then following up with great reflection questions, asking questions to promote what is working, what is not working, and how do you think we can change this? And then providing that very important feedback, which is information provided based on your observations, and providing comments and questions to our parents that are designed to build the parents' level of understanding. So these are the 5 coaching characteristics that Rush and Sheldon has put out for us. And their research has been really pivotal for all of us in early intervention. The reason we use coaching, and I know y'all probably know this, is it is a collaborative relationship between the caregiver and the expert. And research has proven that this builds capacity, right? And this builds their skills. It's the best way to make changes. And so that's why we use these strategies. And we're lucky to have it broken down into these 5 different characteristics so we can look at it closer for mealtime. Okay, so our next one, ways to use a coaching model to improve. So I tried to kind of summarize all that and put it into some understandable terms and give us some real life strategies on how we can use this coaching model. One, we're going to connect with the caregiver. That's that joint planning piece. 2, we're going to watch mealtime in the natural environment. 3, we're going to plan to be at a mealtime and to assist with the mealtime at the next visit. 4, we're going to ask questions that promote parent thinking. And 5, we're going to give constructive and meaningful feedback. So connecting with the caregiver, what does that look like? It looks like listening more than you speak, and this can be very challenging. I know for myself, it's challenging to just sit back and watch, but that's sometimes what's necessary during our first sessions with our caregivers. Being realistic. Using what they have in the home. This is super important. A lot of our families, as you know, just don't have the means to get new, buy new, and use new. So we always are trying to use what we have in the home. And then encouraging the caregiver to leave. I'm always sitting to the side. Sometimes I offer to sit in the living room while mealtime is happening in the kitchen, just so I don't become a distraction, especially in the beginning when I'm really trying to use that observing piece. Number 5 is recognizing those cultural strengths. This is so very important. All of our cultures that we work with have strengths, especially during mealtime. We know that food and mealtime and gathering with families is really important with the cultures that we serve. And so just being able to recognize this as professionals, I think is very important. And then finally, taking an interest in the child, what they like, what they don't like, and recognizing that they have their own wants and needs, and just really trying to provide support in that area. The third part about using a coaching model for practice is watching mealtime in the natural environment. And this is when we're going to really look at 3 different pieces today. We're going to look at nutrition and food types, positioning needs, and tool use. And I want to defer to the handout, the resource guide, where I have the developmental feeding chart. We talked about this in our part 1 session when we were looking at identifying delays amongst our infant and toddlers. Well, now we can pull that back out and use it when we're sitting with our families at the table. And here you can see I have divided it, and 3 of the columns are labeled. One is nutrition and food types, positioning needs, and the last is tool use. And I thought these 3 things were really important to highlight because no matter what your specialty is or what kind of health professional you are, you can encourage your families to make changes in these areas to support feeding and mealtime for their infant and toddler. So you're going to want to use something like this to help guide you. So first, we're going to talk about nutrition. Nutrition. For infants, for birth to 12 months, we know that the primary source of nutrients is going to be breast milk or formula. I really like to defer to the resources, I've listed them in your handout, that are up to date. For example, myplate.org is a USDA tip sheet for infants, and I've listed a whole bunch, not just MyPlate, but as you know, nutritional recommendations are changed periodically. They're changed, they are updated for us adults, and they're also updated for our toddlers and infants. So sometimes we're not always on the brink of the knowledge that is put out there. That's why I always like to defer my families to the resources that are online and most up to date. So I always try to utilize these websites and try to point them in that direction to give them nutritional guidelines. I also try to defer them to their pediatrician and ask for nutritional guidelines from their pediatrician. Lots of times they do give them, and I always try to work off of those guidelines from their doctor. And then I also like to bring visual reminders. Many of the times that I go into homes, I'm seeing a lot of overfeeding of our infants and toddlers. I'm not sure if that's what y'all are seeing, but I love to use a visual reminder. For example, a ping pong ball. And I have my little ping pong ball today. I carry it around with me to make recommendations and reminders to families that when their baby is 1 month of age, this is the size of their stomach. And I have other tools in my bag that kind of show them how small their toddler's stomach is compared to how big ours is. And this really helps to, just having a visual helps them to understand nutrition a little bit better. I also try to define complementary feeding. This is a relatively new term. We've talked about it before, but it's important to emphasize it again. This is a period of solid food feeding between 6 and 12 months, and it does exactly what it says it is. It is a complement to their primary source of nutrition, which is breast milk and formula. The purpose of complementary feeding is to expose infants to tastes and textures of food, and this facilitates cognitive and just general brain development. When between 6 to 12 months of age, we're exposing them to tastes and textures of food. And all feeding therapists and nutritionists recognize this. And it's important for our families to see the real reason between putting food in front of these babies between 6 and 12 months. It's really tried to grow that brain development for feeding. but not necessarily for support for being their nutrition. And that's something that families tend to have difficulty understanding. I like to use a general chart for nutrition, and I put one up on this slide. It can be kind of confusing to families. As you can see, it's not really easy to read, right? How much is a serving? How many servings? This is just a general toddler nutrition chart. And you can kind of see how families could get confused by this, right? I mean, what is a half a cup of milk or yogurt? What does that look like? Unless we don't really know unless we pull out our measuring tools, which I definitely do. I pull out my measuring tools and my cups, and I encourage you to do the same when you're reading these charts with your families. I like to use a general rule of thumb. It seems to have worked pretty well for me, it just really helps families to visualize what they're actually putting on the tray in front of their infant and toddler and the amounts. For example, my general rule of thumb is 1 tablespoon per age per food group. So for example, a 1-year-old will eat 1 tablespoon, here's my tablespoon, of fruit, 1 tablespoon of vegetable, and 1 tablespoon of protein, and 1 tablespoon of carbs. Just a general rule of thumb, right? And to see this amount, this small amount, I mean, this is like 1 strawberry, maybe, if it's a big strawberry. So we're not putting 5 strawberries down on that tray table. Or maybe it's just 1 egg, right? I walked into a home the other day and they were so excited their baby ate 3 eggs. That's awesome. What a great source of protein. But they're not going to be hungry in 2 hours, which is fine, but the parent needs to realize how many calories and how much that is. And so really having a visual again helps. All right. And also, when we're talking about nutrition, I like to educate families on meals, right? So 5 daily, that's what I tell my families. So our toddlers are eating every 2 to 2.5 hours, and all 5 meals can have nutritious foods. This is important because I think a lot of times our moms and dads, they're throwing out the snacks, right? But it doesn't have to have snacks. We don't have to give out goldfish. These snacks can have a nutritious base to them. And then I also want to emphasize that 5 daily meals is about what your infant is eating too, right? Our infants are eating every 2 to 2.5 hours. So the frequency of eating between infants and toddlers is not much different. We don't just go from feeding our babies every 2 to 2.5 hours to feeding our toddlers 3 times a day. And then trying to supplement with snacks, right? So I think that's important to talk to families about. I think this frequency in meals really helps them to maintain a good, healthy diet, and it's a frequent exposure to different foods. And then I also like to emphasize that toddlers and infants, they only have attention span for about 15 to 20 minutes. If they're in that high chair for 30 minutes, that's okay, especially if they're sitting with family at breakfast. You can give them a book, but really their attention to meals is going to be about 15 to 20 minutes in length. And so I try to tell that to families. I also try to communicate that there's no need for a plate. There's so many great plates out there to buy, and they're fun to use. However, using the tray on their tray table or the table that they're sitting at will encourage self-feeding and will eliminate them tossing the food on the floor, right? So sometimes parents get worried about them tossing their food and all that. I just say, well, let's eliminate the plate. I make that recommendation a lot. I try to encourage my families to offer 3 foods at one time. I'll say, like, how about if with those goldfish we throw in some bananas or some cheese? I try to say starch, vegetable, fruit, protein at every single meal, and that's 5 times a day. That's a lot of work, and I recognize that, but I try to encourage my families to kind of move towards that or prepare for that. I also try to tell my families to offer different foods at any time of day. So I give the example, and everybody likes this, that bacon can be eaten at any time of the day. It does not have to just be eaten at breakfast. And when we kind of break down that barrier, I feel like families they're a lot more free, right? They can offer Cheerios, for a snack at 4 o'clock in the afternoon. They can offer eggs for dinner. We got to kind of break those barriers down of what food should be offered when. Some nutrition don'ts. So there are routines out there that do not support healthy eating. One of the things that I'm always trying to discourage is nighttime feeding, especially after 1 year of age. Generally, around 9 months of age, our children should be able to get all their nutrition during the daytime. We know it is fact that nighttime feeding interrupts sleeping, which isn't good, and it creates poor digestion. Our GI system needs a good 12 hours of rest. If they're eating during the night, then their stomach is creating acid, and that acid and laying down then generates into acid reflux, which we know creates a negative connotation with mealtime and eating. So nighttime feeding needs to be eliminated, and this is very hard for families. I would like to revert back to our responsive feeding techniques, because a lot of times families are saying, but they're hungry at night. I get that a lot, and it's really that they just want to be comforted at night, not that they're hungry. And of course, we're not the moms to those babies, so we don't know. But I really try to emphasize, okay, are you sure they're hungry? Let's talk about what they're eating during the day and work through that with our families, because this is one that's very hard, very hard. Another nutrition don't is overconsumption of cow's milk. We know that cow's milk is not nutritionally complete. That is a fact. We know that. So, and it is used as a serving of dairy. That's what it's used for. And at 18 months, it is only recommended that about 3 cups, and that's actually a measuring cup full of milk, are recommended for our toddlers. We know that cow's milk can cause increased congestion, and we know that it can prevent, because it's so high in calories, consumption of real foods. And then I always try to make it a rule that it should only be provided via a cup after 18, I really say 12 months. I never want to transition my babies from a breast milk or a formula with a bottle to a cow's milk in a bottle. I always try to kind of have them make it be a more like a regular toddler cup, which we'll talk about in a minute. But overconsumption of cow's milk is something I see a lot. Look, I have homes that I walk into all day that have about 40 ounces of cow's milk that those babies are consuming. And that is a concern, a nutritional concern, and they don't even realize it. 5 cups of milk is 40 ounces of milk. So like 5 actual measuring cups. So if you look at some of the sippy cups out there, they're holding about 1.5 to 2 cups in them. And if I had one to show you, I would, but I don't, because I don't like them, and we'll get to that. But I will say that, like, so if you feel, if your mama's saying that they're filling up their sippy cup 3 times, that could be 5 total measured cups of milk, which is about 40 ounces of milk a day. So this is just something really to kind of measure out and look at with your family, so that you can process through, okay, is my baby getting too much cow's milk?
We have a question, Kimberly. Does the same rule apply to breast milk?
So breast milk, no. Okay, so breast milk obviously doesn't cause that increased congestion. It doesn't have as high of a caloric. I'm not sure the calories on it. I think it's dependent, but it doesn't have the like fullness to keep babies from eating a lot of foods. However, overconsumption of it does yield to less solid food eating. And this is actually one of my biggest challenges, right? Because if they're breastfeeding all night, they're getting so much breast milk and they are not going to want to eat during the daytime. And then to say to mama, well, we got to know how much. Well, it's impossible to know how much breast milk they're getting. So, to answer your question a little more succinctly, yes, I feel like that this does cause reduced oral food consumption, too much breast milk. That's very challenging to communicate to mom. But if they're wanting their babies to eat more solid foods, we've got to limit that consumption. That's a challenging thing, especially when some families feel differently about that. But it's the math. Yeah. I hope that answered your question. It's a sensitive subject. I always realize that, and I try to walk very sensitively on that because when you're telling a mom, okay, we got to limit this, I mean, they're feeling that as like, I have to reject my baby, and that's very hard. But again, we're talking about, 12 months and up, because at 12 months and up, we're wanting them to eat more solid foods. 12 months and under, their primary source of nutrition is going to be that breast milk. So, okay. So, another routine that does not support healthy eating that I wanted to mention, and this is another hot topic, is grazing. Grazing is defined as providing foods at all times of the day. And we know that evidence-based research suggests that grazing significantly limits caloric intake. And this is why. Usually, the foods put out for grazing are carbs. And carbs is a sugar. So our babies are walking over and they're eating a few bites of this carb or sugar, and then they bite it, chew it, and it goes into their tummy, and there's an immediate signal to their brain that says, I'm full, because that's what sugar does. It gives this immediate instant gratification of fullness. And so then they're like, well, I'm done. I don't need any more. I don't need to eat anymore because I am full. Let me move on with my play activity. Well, then this sugar runs out, and in 30 minutes, they're hungry again, wanting another food item. And so they have a bite of their Cheeto or goldfish, and the same routine happens, and it's a cycle. And so that's why it's really hard not to even start grazing, because it's much harder to stop it than it is to prevent it. So I really try to educate our families early on that meal times need to be more structured, and they need to be, I mean, like their cultural, but their cultural ways suggest. I mean, they have other things to do during their day, right? Like play, read books, go outside, help with the dishes. I mean, involving our toddler in all these activities, and not just eating and taking bites of food all day. Yeah, this is a hard one too. Really hard to encourage families to pick up that food. And I try to do that with, let's have them sit at the table for meals. And there's a lot of different strategies. But once they kind of can understand that this facilitates change, they're much more willing to do it. Okay, again, referring back to our resource handout, I have listed some really great websites and resources on this handout for nutrition, and I encourage you to seek them. Again, the USDA one was one I listed on a slide, but then I also have healthychildren.org. I have the CDC Gov has a milestone tracker app. I have eatright.org on this sheet, and I really love it because it gives nutrition recommendations for all ages. I have the CDC has more videos, and then feeding quizzes by the USDA, and then feedingmatters.com is another one that gives some great nutritional references. So I encourage you to check that out. Okay, we're going to move into positioning. Here's our Zoom poll for this. What is the 90-90 rule for positioning during feeding? Does anybody know? Oh, wrong one.
Yeah, sorry. I think this is a chat one.
Okay.
All right, so we're seeing a couple of answers come in here. So we asked, there was a question to repeat. So Kim, she's asking if you know what the 90-90-90 rule is for positioning during feeding. Kimberly, do you see some of the answers coming in here? It looks like some of our folks are right on here.
Right on the money, yes. The 90-90-90 rule. Super easy to remember. It'd be great if all professionals who enter in the home knew this rule. Let's get to kind of describing it. Okay, so the reason for positioning for it during mealtime is it provides security. And that's important because we're asking our babies to do like hard things. We're asking them to eat. We're asking them to, I don't know what's happening. We're asking them to do, you know, the hardest thing is for them to breathe, and then the second hardest is for them to eat. So providing that security is super important. Positioning also communicates mealtime. So when I was talking about grazing, this is a way to communicate mealtime, is putting them in a positioning device. It is time to eat. It is not time to eat. Positioning provides physical support so that baby must only and can only focus on eating. And this is really important to recognize that, you know, we're asking our babies to learn this new skill of eating foods, and we need to position them and support them the best way we know how to. So that's where the 90-90 rule comes in, and many of you got it. 90 at the hips, 90 at the knees, and 90 at the ankles. So in my opinion, the best type of chair is age dependent. These are all really great chairs that I have listed up here. The thing about positioning to know is that your chair must have access to a tray or a table access. So if you can see this brown chair down here, this is a restaurant chair. I love this chair for a variety of reasons. But we need to pull it up to a table. So recognizing that is very important. The tray should be at the breast line. This is great because we want our babies to be able to use their hands to touch those foods. And it encourages self-feeding, which we know will improve quantity. If they are able to feed themselves, and they are more likely to eat more foods. The goal for positioning is always to put those hips in an anterior position. Anterior means forward. We want them to be over their food. We don't want them to be back and to be staring off into space or into the ceiling. And so that's the goal for our positioning device. All right. Oops. Positioning. Here's my no-no tip for positioning. They must support the feet to achieve maximal core strength. I love an IKEA high chair because it looks so trendy in the white kitchens out there, right? However, they do not have a good foot support. And so there are lots of YouTube videos and how-tos out there on how to get this high chair to have a wonderful foot support. So I encourage my mamas that have this high chair because this little sweet baby, he's going to have a hard time eating if he can't put his feet on something and achieve that maximal core strength. And I like to tell my families when I see my babies just hanging like this, I'm like, how would you like to eat a meal, like a steak or chicken meal, out in the middle of the ocean on a surfboard? That would be what like our baby is trying to do. Kind of hard. So we want to encourage our families to use what they have and create a foot support for high chairs, even ones like these. Okay, the bumbo. The bumbo. I have a love-hate relationship with the bumbo. The bumbo generally does not provide good positioning for mealtime, and it will always put those hips in the posterior position so that baby's leaning back and looking up. It has very poor ability to support their head and their shoulders during mealtime. So it is not ideal for feeding. However, it is advertised for feeding. The thing is, our families do not have a lot of space in their homes, and they see this and they think, oh my goodness, I can put my baby on my table while I'm eating. I can put them on the counter. This is perfect. I'll just whip this out, put them on the counter, put the tray on, and they'll be able to eat. And I love the idea of this, and I always want to respect our families don't have a lot of space. But unfortunately, the bumbo is just my least favorite positioning device for mealtime. So if you can, please discourage your family from buying the bumbo or utilize this only for play as opposed to mealtime, because it's a challenge. I use all kinds of towels and ways to try and make this work. And again, I always try to work with what the family has, but at the end of the day, I'm usually bringing a new high chair to this family who has a bumbo. I will admit that. I love to shop on Marketplace and Goodwill, and I will just come in and say, here, look what I found you. Let's use the bumbo for something else. So okay, our positioning to get from 90, 90, 90, I like to use all different kinds of things in the homes. I like to use pool noodles, towels, stuffed animals. Does brother have a old shoebox he wants to recycle? I've used that many times. And I like to use duct tape to kind of make them all work and fit together. And I encourage you to do the same, because when we work this hard to make that 90-90 rule work, it alerts the parents to the importance of positioning. And I really think that's important for our babies to learn how to eat better. Tools that build oral motor skills. We'll move right in from positioning to tools. This is that third column on our chart. I have listed a variety of tools here. Their names are in your reference sheet, your resource handout. The first one is a mesh food feeder. I love a mesh food feeder for texture and taste for our infants and toddlers that are learning to explore. I love a silicone small infant spoon because these are very affordable and they give the just right size bite amount for our pureed and mashed foods for our infants, and they teach our babies how to put their mouth around a spoon. I love to utilize this Nuke food masher, which is the one right here, to communicate to families that they can use what's on their table, add a little water to it, and make a great baby food. They don't have to go and buy something fancy. I love to use the take and toss fork and spoons. These are very inexpensive and can be found anywhere, and they're a great self-feeding device for our infants and toddlers. And I just love them because they're so easily accessible. This fourth item right here, this is just an oral motor bite chewy toy. The reason I put this up here, and there's so many different kinds out there, I've never actually used this one that I've put up there, but what I like about this one is the knobby pieces that you can see here. A lot of our oral motor toys and tools, they're just circles, right? Because they don't want baby to choke or gag. But from research and from a feeding therapist standpoint, these knobby pieces are so important because they facilitate tongue lateralization. They facilitate the tongue moving back and forth and the biting that needs to go on when they're biting those chewy tubes. Okay, so now we're going to look at more tools. These are specifically cups. I get a lot of questions about cups. The first cup right here is a Nuke Learner Trainer cup. I have not listed that on your resource handout. It did not make it. But I'm thinking many of you have seen this. This is my first step to transitioning off the bottle. I really try to get my babies to drink from this cup. Then I love a straw cup, and I'm always trying to get our babies and families to not work towards drinking towards a sippy cup, but to work towards drinking to a straw cup. And this is a weighted straw cup that's very easy for some of our infants who have typically developing motor skills. It starts about 6 months that these babies can drink from a weighted straw cup. OXO also has one. This is a Munchkin weighted straw cup. This is a take and toss straw cup. And I really like this straw cup because it's so easy. It's easy to find, it's cheap, and it's not fancy, but yet it serves a really great purpose. It's just a little big for our toddlers to hold, but it has a great suction to it, and sometimes you can squeeze it and help those babies learn how to use a straw with this nice take and toss straw cup. This is a bathroom cup, and it is one of my greatest, most used oral motor tools because it's easy. I can hand them out, and it really helps babies learn how to regulate their flow of liquid and toddlers, and it's great for developing those oral motor skills for eating. These are tools that can prevent the development of motor skills for feeding and speech. And we all know this probably, but the PASI is really working against feeding and oral motor skills for speech. And so we're really trying to encourage our families to transition off the their babies off the PASI at 18 months. The doctors and physicians, they support this. I know as a mom myself, I had a hard time with this. I got better as I went on and had more children and taking the PASI away earlier. But I think it's important for our families to recognize that this can be a real challenge, and that they want to take it away earlier than later because later is much harder. And it really, if you think about all three of these tools, the PASI, the sip cup, and the bottle, they are using the exact same oral motor pattern, right? And it's just that suck, swallow, suck, swallow. Well, that baby's been doing that since birth. We've got to transition to a new skill. And that's why these tools can prevent the development for feeding and speech. And that's really hard for our families that love a sippy cup. But I just try to encourage them to utilize a straw cup instead of the sippy.
Kimberly, is this a
Yes.
good time to interrupt? We have two questions that have come in.
Yes.
One question is to go back to the pool noodle. How would you use a pool noodle to support positioning?
Oh, yes, I love a pool noodle because they're very inexpensive. So we usually chop them right into pieces and position them to the sides, if you can see me, to the sides. And let's see if I can kind of scooch my slides back so I can kind of show you best on a chair. Okay, so this top high chair, lots of times it's really big for our infants, right? So I'll put a pool noodle here vertical and a pool noodle here vertical, just to try and get their shoulders rounded, right? So they can get their hands at the tray table. I just think they're great little positioning tools. So
Well, thank you. Yeah, it's kind of like a rolled up
yeah.
towel or washcloth. Another question is from Suzette. She says, I have a child that eats more or better when they're sitting on mom's lap versus being in their high chair. He has oral defensiveness, so I think being restrained is aversive. One of his goals is to sit and eat in a high chair. How do I promote this? And I think one of the questions that we're seeing through here too is that culturally, some children do sit on laps. They don't sit in high chairs for feeding. And I wonder too if maybe some of the reasons why feeding is a challenge, or the families prioritize this and you're in there working on feeding, might be due to positioning needs, right? Something might be due to motor development, but maybe sensory processing issues might be, oral defensiveness might be different and might not require the same positioning kind of supports. That's just one question I have. I think we're seeing come through.
Yes, and I have that challenge too every single day, that families are like, well, this isn't working. Can you sit in my lap? And I'm always like, yes, yes, yes. Sitting in the lap is fine. But, while they're in the lap, can you get them to be more independent? Can you sit them at the table? Can you help, can you facilitate at their elbows for them to reach for the food? Can you make sure you're not holding the cup? You're not holding the bottle? If sitting on the lap is fine, that's great. Or is it a avoidance behavior, is sitting on the lap on the couch because they don't want to eat at the table because they're overwhelmed by what they see at the table. So I just think using your grading skills, using backward chaining, all of your great behavioral techniques that you can pull from your tool bag to try and facilitate greater independence for mealtime. So I understand that. I see that all the time. And I love that you have a goal for it. So you're working towards it. And maybe that just means, baby's going to sit on the edge of their seat, right? Or on the edge of their lap rather than full arms holding, right? So just kind of backwards chaining towards that.
All right, thank you.
All right, pouch foods. This also brings up kind of a challenge. Pouch foods are great for good and for on-the-go meals. But I want to tell you what they are not good for. Baby is not able to see, smell, or touch these foods. The pouch food uses that suck-swallow reflex to propel the food back and fill up their tummy, and it totally reduces any kind of sensory input. Sensory input is necessary at infant and toddler level to build cognitive skills. So it's really important that we try to steer our families away from pouch foods. The negatives about pouch foods is they require sucking to eat and does not build more oral motor skills for chewing. And they often come in mixed food pouches, so baby is not able to make a connection with the flavors. And this is something that we don't often think about, but if we're giving a baby a strawberry, the flavor. So I try to say, hey, this pouch food, can we put it in a bowl? Can we use a spoon? Don't throw away those pouch foods. They are very expensive. So let's just put it in a bowl. That's always my goal. So next, we want to plan to assist with mealtime using all those different strategies we have learned about. Plan to assist with mealtime with that family. And that means understanding the schedule for the family, letting the caregiver lead, and respecting those cultural norms. Always ask questions that promote parent thinking. So what is working? What is not working? How did using a chair or a high chair work for you this week? We talked about, having him sit on your lap a little less last week. How did that go? Always avoid those yes and no questions. And always encourage open-ended questions. So, for example, we talked about sitting in that high chair. Why did baby need to walk around during snack? And that's when you can talk about those sensory things that maybe baby's experiencing, or the behaviors, or maybe what happened this morning, or baby woke up at 3 a.m., or, and you're generating that problem solving with the family. And then always provide that constructive, meaningful feedback. And using the coaching strategy really emphasizes this, and that's why I really like it. I like to use what I call a sandwich technique, in that I always say I have a specific positive from any home that I'm in, and then I have a corrective statement where I'm trying to guide them to something or the next step, and then I always end with a positive. So, for example, I really liked how you are having baby hold his own bottle this time. You've done that for a week and you're seeing improvement. That is so great. I know our goal is for him to sit at the table and hold his own bottle. So I like how you're working towards that. But I understand how he needs to sit in your lap for now. So I really try to emphasize that. And I know with all our families, we can find something great that they're doing, especially the foods. I love how the different cultures that I work with always have the best baby foods, way better than Gerber. So I always find something, and I know y'all do too. So just in summary, ways to use this coaching model to improve. We're going to connect with the caregiver. We're going to watch mealtime in the natural environment. We're going to plan to assist with mealtime during our time. And we're going to ask questions that promote parent thinking, no yes, no questions. And then we're going to give constructive and meaningful feedback. Going on to our last point, and the most important is achieving that long-term goal, which is empowering the parent. And this is the biggest reason why using all of these parent intervention strategies helps. Just real quick, true or false, by 24 months of age, children identified with feeding issues are more than twice as likely to experience developmental delay and 4 times as likely by 30 months. What do y'all think? True or false? Yep, you know it. It is true. The thing that's staggering is 4 times as likely by 30 months. That's big. That's before age 3. So we really have to empower our parents at an early age. To really understand why these strategies are important to use and to get them involved. So the 4 reasons that I want you to walk away with to use this parent-led intervention strategy is 1, to empower the parents, 2, to improve the value of healthcare services, 3, to catch developmental delays quick, and 4, you know that this has the largest impact on general infant toddler health is good nutrition. And so we talked about how to catch those developmental delays quick, but just knowing that these are the first steps to teaching your parents how to advocate for their own child, and feeding problems are long-term sometimes, and so we want to encourage them at the beginning. So in summary, these are the 4 things that we've talked about. Please let me know if you have any questions. And here's our little post survey that I would love for you to fill out. And Lorelai, if you could drop the link and let me know any questions you might have.
There's the link now. And Kimberly, while they're completing this, we do have a long list of wonderful questions. Like really, you can tell folks are out there doing this work and have very specific and nuanced questions. So I'm wondering, for the sake of time too, you and I had talked before, perhaps I could collect all of these questions and we can answer them through email.
Yes.
Would that be great? It's kind of like
Yeah.
an answer questions. And then anyone who's registered for this session, we'll just send an email out to everyone with those answers to the questions. So if you'll go ahead and put those, as soon as you finish your survey, if you have any additional questions, please let us know, and we'll make sure that we sort through those and get an email collected. In the meantime, Kimberly, do you mind going to the next slide? So everyone, you should have gotten the link to the handout in chat, but if you came in a little bit later and need it now, I'm going to go ahead and put the handout in there now. As Kimberly mentioned, everything that she's talked about today, there's really wonderful supporting information, links, all of that in the handout. So if you'll go to the next slide, I just really want to thank you, Kimberly, for being here and really, working hard to help us get each of us be able to find kind of additional information to add to our feeding challenges tool belt, because we know it's so nuanced, it's so specific, and as you started out with, it's really driven by the family, right? So we're using a coaching perspective. Families are saying that this is their priority, and you're helping. Everyone here is trying to help families in a culturally responsive way. So we really thank you for helping us each be able to kind of engage this presentation in a way that we all are able to learn, to take something away. For those of you, if you'll go to the next slide, for those of you who are interested in receiving certificates, we have some folks who are new to us. We just want to make sure that you know that in your email, Make sure you check your spam folders and all of that too. But in your email, if you registered yourself for the session with your email, you should be receiving now, you should have in your inbox an email from us with a link to the survey asking for your feedback on the session. You have to complete that survey, and then you will get access to your certificate for participation. If you'd like to view the March training, if you didn't have a chance to do that, or if you did that and then also want to complete the survey, you can find that on our website. I'll go ahead and put that link in here now. So that's there for now for you all to be able to view, along with all of our prior wonderful talks on Tuesdays, which are available again for you to watch when you have the time and as needed professional development. And then you do have access to the certificate for professional development hours then. We look forward, hopefully, to seeing you all next month. The Constant Contact is just about to come out for our talks on Tuesdays, May, June. We are focused on preventing expulsion, suspension and expulsion in childcare settings, and how we can work with families and childcare providers when there are behavioral challenges that are impacting families. So we hope to see you then. Look out for that Constant Contact, and we will collect those questions and get an email out to you. Thanks, everyone.
Thank you so much.